Today, I would like to present you about a multicenter evaluation of a combination of a MP brush and also plasma EBV DNA in detecting local failures in NPC. Here are my disclosures, and the study was approved by the joint CUHK and NTEC, as well as the Kowloon Central and Kowloon East Research Ethics Committee. So as we all know, the disease is endemic in the southern China and Southeast Asia, with an annual incidence of 15 to 50 cases per 100,000. It's also the most common head and neck cancer in Hong Kong. And in our locality, 95% of them is undifferentiated carcinoma, and it is associated with the Epstein Barr virus. So the primary treatment for NPC includes radiotherapy plus or minus chemotherapy, depending on the stages. Despite this treatment, the local failure rates is up to 10 to 30% according to previous studies. And also a multivariate analysis of 97 patients undergoing salvage surgery during the recurrence. It proves that surgical margins is an independent negative influence on the local relapse-free survival as well as overall survival. And because of this, early detection of recurrent or residual disease could affect possibility of surgical salvage. So as we know, the maxillary swing nasopharyngeectomy is the gold standard of treatment for local recurrent disease. It was quoted that the 5-year overall survival and the 5-year local control was up to 50 to 60% and 74% respectively. With undergoing such a major surgery, sometimes the concerns would be operative and also cosmetic morbidities. So endoscopic nasopharyngectomy is emerging. Is a technique that's focused on small tumors or T1-2 recurrence disease. So a pooled analysis of a case series with literature review by the CUHK in 2017 that included 18 cases as well as 300 cases review. It was reported that the recurrence-free survival and overall survival were 86% and 83% respectively. And the resection margins were negative in up to 90% of the patients who underwent endoscopic nasopharyngectomy for recurrence. So endoscopic nasopharyngectomy seems to be the upcoming very promising surgery in tackling small local recurrent disease. So first, we'll go through the modalities in detecting local recurrence. This is essential, as I said, to permit surgical salvage before the locally aggressive lesions are deemed inoperable. However, it is challenging because of the change in mucosa and also axillary dysfunction, which can affect our diagnosis using endoscope. A study reported that the specificity and sensitivity in detecting local recurrence were about 80 to 95% versus 30 to 60% respectively. The technique, the limitations including operator dependence, and as I said, post-radiation mucosal changes, the crusting, the secretions. And there's also possibility of submucosal disease, which will delay our diagnosis. And in that case, we usually perform a site-targeted biopsies to improve our sensitivity. And besides the technical difficulties, we also have to take into account of the cost of maintenance and storage of the equipment required. sometimes biopsy can be difficult when we are facing cases with distorted anatomy, especially choanal stenosis or extensive scarring of the nasal cavities. So imaging is also helpful tools in detecting local recurrence. MR offers superior soft tissue resolution, whereas CT provides a better bone examination. PET-CT provides a sensitivity up to 90%. When using combination, the sensitivity can be up to 95%. Some studies also advocate the use of DWI MRI, which can reflect the tissue characterization with a better tissue cellularity, and also it may even show the integrity of cell membranes and fluid viscosity. However, there are limitations which include post-treatment inflammation and the presence of ORN, which may lead to overestimation of disease. And of course, the availability of these imaging modalities are also limited because of the ever lacking manpower in our radiology department in the public sector, and patients may not be able to afford private scans when undergoing these multi-modality imaging. So the plasma EBV DNA is also known as the liquid biopsy. Analysis of this DNA was useful in screening for early asymptomatic nasopharyngeal carcinoma, according to this CHK studies, and the sensitivity and specificity are as high as 98%. So another tool would be an NP brush called the NP screen. In detecting primary NPC, the sensitivity and specificity are up to 90 to 99%. However, this tool is only available overseas, and it takes 1 to 2 weeks for shipment and analysis. It is the use of a quantification of EBV DNA using a quantitative PCR. It is used to detect the Epstein Barr nuclear antigen 1 gene. This is a video on which showed the technique of. There's some technical error, but just a video showing the brushing technique of the nasopharynx, in which the patient just opened the mouth, and the technician or doctor would put in an angled brush to brush the nasopharynx to obtain the tissue sample. It is usually easy to perform and well tolerated in patients with post-RT, as the gag reflex are diminished, and no local anesthetic is required. And when preserved in room temperature, it can be kept up to 30 days. And according to the company, for primary NPC, the detection level for positive cutoff would be a 2.6, whereas a negative cutoff would be a 1.7, and equivocal in between these two values. So there was a study undergone by the Hong Kong U colleagues, which showed that there's no statistically significant difference in the mean estimated detecting level among the different local recurrence T's classification in these patients. It was a prospective cohort studies of 30 patients with a mean duration between the RT completion and the NP brush was up to 108 months. So the mean cutoff value was 2.38 among the recurrence group. So although these two modalities have been used in detecting primary NPC, they have not been extensively evaluated individually for the detection for local failure. Previous studies show that EBV DNA alone is not sensitive enough to detect local recurrence, which can be affected by the tumor volume and also the T classification. So therefore, we would like to evaluate the two and the combination of both investigations. So the study has been ongoing for 5 years, and now we have included 80 patients with 24 test subjects, the recurrent subjects, and also 56 controls. So both groups of the patients would undergo MRI of the NP. For the local failure patients, they would have biopsy-proven local failures, and as well as undergoing MRI to rule out regional metastasis. And they would both undergo the brush and the blood test for EBV DNA. So these are the statistical analysis which we use in evaluating our data. So as we know, the male to female ratio for NPC about 3 to 1. So which is similar in our studies, and the mean age is about 56, 57 years old, and the primary staging are not quite symmetrical. More of the patients have a higher stage at the control group. So among the recurrence group, most of the patients had early disease. Most of them had T1 recurrence upon diagnosis. And the mean value for recurrence using EBV DNA would be 40. And the mean value estimated detecting level in NP brush would be 2.5. Note that the range included 0, meaning that no matter there is recurrence or not, some of the test subjects may have 0 in either the EBV DNA or the NP brush. So this is the RLC curves, and we use the Kowloon index to capture the performance of a dichotomous diagnostics test. With the index being 1, meaning that the test is perfect without false positive nor false negative. So we are using the area under the curve to determine the optimal value of these two investigation modality. Usually the higher the area under the curve indicates better performance to predict the presence of a disease. So in our data, for EBV DNA, the optimal cutoff would be 2.0. For the NP brush, it would be 1.98. Noted that the results are quite different from when I underwent the pilot studies, which the Kowloon index was much higher. I think that the results were affected by the fact that the patients with locally recurrence, a few of them had negative 0 EBV DNA, which has made the sensitivity of a EBV DNA lowered than expected. And in comparing the 3 combinations, the cost of the EBV DNA can range from 50 to $130 US. For the NP brush, since this is a patent product, so the cost is relatively high, making it about more than $300 US. So when these two investigations are used in combination, the sensitivity and specificity were up to 91 and up to 81 and 89% respectively. when in combination, the positive predictive values was 74%, and the negative predictive value was 92%. When the cases were evaluated in combination, we have to note that the plasma EBV DNA and the MP brush results have to be truly positive. Otherwise, they would be excluded from the combination evaluation. So in this case, we can only conclude that the high specificity of plasma EBV DNA and MP brush may help rule out locally recurrent NPC, which these two methods may provide additional surveillance modality when being used in combination. So we are looking to expanding the study and recruit more cases, and calculating the power of the study, we will need about 160 subjects to determine the optimal cutoff values for both investigation modalities. So there's still no consensus for the time of measurements using these two modalities, and it is actually quite time consuming in data collection due to the relatively low incidence of local recurrence. And the cost effectiveness is still one of the major concerns, as the MP brush is still a patented test. And skills can be trained in performing the MP brush without much difficulties. So hopefully we can establish a reliable and affordable non-invasive screening method in detecting early local recurrence in the future. And we can promote the two tests among non-ENT practitioners, especially the oncologists or family physicians who routinely follow these NPC post-treatment patients. And hopefully we can reduce unnecessary MP biopsy or endoscope, especially in this COVID era. So I would like to thank the following seniors in CHK, Hong Kong U, and also Kowloon Central Clusters for helping me in these studies. Thank you very much.